My name is John Hawkins. I'm with the Texas Hospital Association. We're here to express our support for House Bill 145. We very much appreciate the state-supported staffing that you have been very diligent in providing through each surge of this pandemic, and we very much appreciate it being included in this bill to help with any potential cash flow issues going forward. I think it's important to note that hospitals are experiencing increased costs beyond the direct staffing costs that are being covered by this bill. Hospitals are working very hard to retain their current staff so we don't have to rely on contract staffing, so they're doing things aggressively like retention and recruitment bonuses, and that obviously is an increased cost. So we would recommend that as this funding gets reimbursed by FEMA, you actually allocate that to providers to deal with these costs beyond what the FEMA is reimbursing. And that would be very helpful going forward. And just to point out, the existing federal funding only goes through March 31st, so that's not going to cover really the most significant two surges that providers have experienced in Texas, both during the summer and then the Delta surge. So this would actually provide a mechanism. We believe those funds would still be restricted to ARPA eligible expenditures, even if reimbursed by FEMA. So that would be very helpful going forward. We also should point out there's extensive transparency related to these funds, both federal guidance that just came into effect last week, and you all passed House Bill 809. Chair Olverson carried that bill on this side, which has HHSC reporting. So you'll have clear transparency on all of these funds and how they match up. And we also support additional funds for the Nursing Shortage Reduction Fund. That is a long-term strategy to help with workforce. Thanks.
Thank you. Vice Chair Gonzalez.
First and foremost, thank you to your association and all the hospitals across the state who have just really been dealing with this for so long. And I just want to ask a little bit of background on the staffing shortages. Can you tell us a little bit about where we are right now, what remedies exist, and what remedies you still need to address that?
Yeah, so again, we very much appreciate the 8,100 state-supported nurses that are deployed across the state, and so that really is the backbone of what's supporting our facilities. But beyond that, there are still considerable shortages. So hospitals are using their own resources to contract with nurse staffing facilities to help build up that infrastructure. As an example, we're starting to see flu. So you might be a kind of a mid-sized or a rural hospital that doesn't qualify for state-supported staffing because you don't have COVID patients, but you are seeing more flu, or you saw RSV. We dealt with that surge earlier. And so you still have a shortage because of the nationwide staffing shortage. So that's very challenging. It's causing us to pay inflationary rates for that staffing. And then, as I mentioned, we're also doing things very aggressively to recruit our own staff and retain existing staff so we can hopefully end this inflationary cycle that we're in with using the staffing agencies.
Well, I know the staff shortage is causing a ripple of domino effect that may impact the industry for long term if we aren't careful. So thank you for helping us understand the issue.
Thank you.
Vice Chair Wally.
Just to understand, when you mentioned the inflationary rate for nursing, what you mean by, and I don't want to put words in your mouth, but for the average person, you're talking about the rate at which, related to the pandemic and the surge of nurses that you need to take care of particular beds, that you're having to pay a higher rate for that particular contract nurse, whereas somebody that's in-house, are on a regular salary cycle and benefits package, and is that what you're talking about?
Yeah. So obviously the shortage of nurses we've lost, and allied health in general. It's not just nursing, but because of burnout, retirement, other issues, because of this continued cycle we've been in. There's a shortage, so there's an inflationary pressure on those contract staff. But then that also forces up what you're paying for your existing staff. And so,
Because some of those nurses that would be, in essence, in-house nurses and allied staff are seeing the dollar signs, particularly going on the contract side. So they're leaving their whatever, I don't want to name any particular hospital, but they're leaving their hospital to go work for a contract agency because they're getting maybe twice, 3 times as maybe a traveling nurse. Is that fair?
correct.
Okay. And then you compound that with, the different surges in the virus and the amount of personnel that's had to respond to it. Is that correct?
That's correct. And RSV now, hopefully flu won't be, we'll be able to manage that. But yes, and then just the regular medical care. A lot of that medical care was delayed because of the pandemic. So all of those things working together have become very inflationary and very costly to hospitals and health systems.
So bring up a good point, because we told hospitals to pause on elective surgeries. Is that what you're talking about, where folks are nursed out now? Trends are going down, and now folks are starting to get called for their elective surgery, which would be, for them, would be important, for that patient would be important. And you're saying that
Yes.
because now travel nurses.
Yeah, so there was
on-
delayed care because of idling of elective surgeries during the surge. There was also delayed care because people were afraid to go to medical facilities because of COVID. And so all of those things together, I think, are working against us.
And then obviously it's putting an enormous amount of strain, let alone on the hospitals themselves, but on the particular staff. We're talking about nurses here, but all the allied
Respiratory tech.
therapists and everybody that works to try to get folks back.
Yep.
I guess back to where they can function again.
Correct.
Okay. Thank you.
Representative Schaefer.
Thank you, sir. I'm hearing from some self-insured businesses in my district. Can you speak to how the hospitals are going to try to work with these companies who have had employees who've had these very extended COVID hospital stays? The state is providing resources, the federal government is providing resources to the hospitals, but just speak to the tension now between these self-insured businesses who are getting these really high hospital bills for these extended stays for their employees, and how the hospitals might be working with those businesses to mitigate those costs.
Yeah, great question. And again, I think that's part of that transparency discussion. At the end of the day, we need to be able to look back and see where, the federal revenue, because ostensibly some of that was for lost revenue and other items. All that needs to come to bear. Obviously, there is increased cost in the system because of the disease. But in talking with my members, I know that they are interested in working with those self-funded employers. Again, a lot of those are working in kind of exclusive provider networks with those self-funded employers. So it's in their interest to work with them to try to manage their medical costs. So I see that happening, and certainly I would, if you had examples of where those discussions weren't bearing fruit, certainly let us know.
Absolutely, because I think it will put us in a very difficult position to explain how all these funds have flowed to hospitals. And we hear from business owners that come out with these bills that might not have been handled differently, and so it's good to hear that. And I do think that that's something that I hope your hospital association will be aware of, that we are hearing those messages from employers.
Great.
All right, Representative Howard.
Thank you, Mr. Chairman. Obviously, jobs, healthcare, these are some of the most critical areas I think we need to be looking at funding that we have here. You pointed out, John, that, and I think you heard earlier testimony, that questions answered that indicated that the FEMA reimbursement would be swept back into GR, and not necessarily, we didn't hear anything yet because we don't know, but how that would be used, if there'd be any restrictions on it, that sort of thing. You're suggesting that for your industry, it would be helpful to have those funds be able to continue to help address the costs that hospitals are incurring directly as a result of COVID. Is that
Correct. And I think also that buys you a little time from a timing perspective. You know, the federal government did just announce another tranche of the provider reimbursement fund, but only through March 31st. So, you know, there needs to be some reckoning of existing federal funding and what this ARPA funding would look like. But what we suggest is you could set up a mechanism to at least collect those costs from a variety of providers and then use those funds as they were reimbursed by FEMA. We would expect that to continue at least through the end of the year to redirect that to address those direct costs to providers beyond what the federal government has already reimbursed us for.
And can you real briefly say anything about how this is impacting your rural hospitals?
Yeah, again, and to Representative Schaefer's point, you know, when you look at the hospital industry, and I think the American Hospital Association just released a report that really showed, in spite of all this federal assistance, there are still significant challenges. And again, not all hospitals are alike. And so I think when you look at those mid-size and independent and rural hospitals, that situation is much more dire for them. And again, the problem they're going to have is that we've created a fiscal cliff, really. I mean, I think the federal government has actually done a good job of directing enhanced federal funding to rural hospitals, but that's not going to last forever. Again, thankfully, caseloads are down. A lot of those hospitals don't necessarily have COVID patients right now, but now they're still dealing with other challenges, and they are competing against the urban areas, frankly, for nurses, if those urban areas can offer a higher wage, and
Right,
those
to your
nurses are
point
willing to travel.
About the nursing shortage we already had before this happened. It's just been exacerbated. And so there are things that we could be doing. You mentioned supporting increases in the nursing shortage reduction program that we have. I know that we also have, and I don't know if we're going to be hearing from the Board of Nursing, but I know that we did not fully restore the 5% cuts, and we could perhaps expedite licensure of nurses getting through the pipeline that the Board of Nursing is responsible for as well.
Yeah, and I think, you know, loan repayment is another area folks have mentioned as well. So I think we need to address the short-term issues, but we also need to keep an eye on the longer-term infrastructure opportunities out there.
Thank you, because clearly the healthcare workers, the hospitals, they have been the ones that have been taking care of all of the thousands and thousands of patients that we've had. And it's just a huge amount that we've asked of you. And so I thank you very much for what you've done.
Thank you.
Representative Schaefer.
How many of your members have had a local government use their federal funds to support the staffing issue?
Not many, but I will follow up more specifically. Certainly when the governor announced to deal with the Delta surge, when he initially TDEM sent out the guidance to have providers approach units of local government for that funding. Many of them did, most of them did, frankly. And I think the challenge was, number one, the staffing dollars were well in excess of what those allocations were, especially when you trended it out, or those funds were allocated or at least encumbered for other needs. But many of them did, and some of them have actually received funding. So I can work on getting a better number for you on that.
It might be worthwhile to know in the aggregate what those funds look like. I do know that in Smith County, they did offer some funds to the local hospitals, but the need was great. But I do think it's worth noting to the members of the committee that local governments receive dollars that the bullseye purpose of those funds was to help with these essential workers. And in many cases, those local governments made the decision, for whatever reason, not to allocate those dollars to local healthcare facilities. So it's interesting how that political dynamic played out at the local level.
All right, members, any other questions? Mr. Hawkins, thank you for being with us. I would just add, it has been a very trying time. We do appreciate everything that our hospitals and our medical staff workers have been doing. It's been also complex because of the incredible number of different revenue streams of relief that have flown into the hospitals, and I think we don't have maybe a full comprehensive view of all the relief dollars that have gotten to our hospitals, because it's much more than what you see just coming through the state. And we have a allied health shortage, particularly with nurses, but that's a critical issue that existed before the pandemic and was exacerbated by the pandemic. And I look forward to, apart from this bill, looking forward to a long-term, maybe a 5-year plan. And I think Representative Howard's been a great champion of the nursing profession, and we'll work together going forward to try to address that. But when we're infusing several $1 billion a year into the same pool of workers, we know what happens then to the salaries, and that's just straight plain inflation. So we're going to have to wean ourselves off of that, or we'll continue to have that.
Quantitative easing, yes, we need to taper.
Well, thank you for being with us this morning.